Well, welcome everybody to the Royal College of Surgeons of Edinburgh's Monday 7 o'clock webinar slot. This is going to be a fixed time and a fixed place for our COVID-19 webinars over the coming weeks. And we hope to do many more webinars, possibly during the week, but there will always be a Monday 7 o'clock slot. The response so far to our webinars has been fabulous, really rewarding. Over 1,300 have registered for this webinar, for instance, and we're looking forward to answering all your questions a bit later on. Next week, I can tell you, is answers for trainees at 7 o'clock, but there may be another one during the course of the week, and we'll let you know about that. Very quickly, our intervention 2 weeks ago over guidance for PPE has prompted a significant response from Public Health England, as we discussed in our webinar. And I would reiterate to all of you out there, my message to those working in the front line under huge pressure to adhere to the guidance and ensure you are adequately protected for the clinical scenario that you find yourself. We really do care about your protection and your safety. So read our guidance, stick to the Public Health England guidance, and look after yourselves. So we would like you to interact as much as possible. At the bottom of the screen, you can see the Q&A button. Please send in your questions, and I am going to hand over to our chairperson for the evening, which is Professor Janet Wilson, who's Professor of ENT Surgery at Newcastle University, works as a head and neck surgeon at Freeman Hospital, and is a council member of the Royal College of Surgeons of Edinburgh. Janet, I'm looking forward to this webinar. Introduce. Over to you.
Good evening, everyone. Our third RCSEd COVID-19 webinar tackles frontline hot topics in 3 specialties. And we're delighted that we've got people registered for this webinar from over 70 countries worldwide. Over the next hour, we hope we can address as many of your frequently asked questions as possible. And we also want to keep responding to your feedback about our COVID-19 webinars. You wanted more capacity and a better balance of graphics and faces, so we have changed our platform to Zoom. You wanted more time for questions, and thank you to the many who have already submitted questions, because those are dealt with head on in our initial content. Your feedback is vital to us to continue to develop the series, and even though it might be the last thing you want to do, you'll have 2 opportunities for feedback. One at the end of the webinar and another one later on in a subsequent email. So without more ado, our first panelist tonight is Professor Philip Turner. Philip is a consultant orthopaedic hospital at Stepping Hill Hospital in Stockport, council member of the RCSEd. He is immediate past president of the British Orthopaedic Association and also the BOA lead on their response to COVID. Phil, over to you.
Thanks very much. So in the next 5 minutes, I want to cover how T&O are addressing the challenges of COVID-19. I'm going to look at a few controversial issues and look forward to the challenge of recovery when we start returning to what people are now calling the new normal. So I'm going to have the first slide, Ryan. So what has changed in trauma and orthopaedics? Essentially, over the last 3 weeks, it's quite remarkable how fast the landscape has altered. Elective orthopaedics is drastically cut back, apart from a few specific conditions I'll come to shortly. The amount of trauma we're dealing with has reduced and is now relatively minor. There are very few road traffic accidents, no sport is happening. Most units have developed direct access clinics for minor injuries, so the emergency departments are unloaded, but there is no change in the incidence of hip fractures in the frail elderly And these are also the group which tend to be COVID positive and will do very badly with COVID. It's now a consultant-led and provided service. Our juniors and trainees have essentially all been reallocated to the emergency department or ITU, with obvious implications for their training, education and experience. Next slide. So the controversial issues for T&O are: what are the aerosol generating procedures? How are we going to manage our supply of PPE if we assume that all our patients are COVID positive and most of our operations are aerosol generating? And then the controversial area of theatre ventilation. Next slide, Ryan. So the definition for PHE is surgery involving high-speed devices as far as orthopaedics is concerned. So we use a lot of drills, saws and reamers. That's pretty obvious. Perhaps also pretty obvious is that you shouldn't use high-powered pulse lavage, because this just sprays fluid everywhere. More controversial perhaps is the role of diathermy and the smoke from diathermy, but that can be removed easily by suction. And there's been a lot of chat on various social media about the risk of using saws to remove plaster casts. But the accepted wisdom is this doesn't produce an aerosol, it produces dust, which can easily be removed with the suction vacuum. Using a normal surgical mask and perhaps a visor should be sufficient. If you want to avoid the problem altogether, then use soft cast materials you can cut with scissors or shears. Next slide. So as far as T&O is concerned, most of our operations are aerosol generating. Our kit in theatre is the full PPE with the FFP3 masks. And you may wonder why we've got the smiley face on the front, but this is to distinguish those members of staff who are actually scrubbed and sterile and those who are runners, because everyone now in theatre looks exactly the same. Next slide, please. So what about theatre ventilation? For orthopaedics, where we're putting in large amounts of metal work, there is no doubt that laminar flow really cuts down on the nosocomial infections. But there's a lot of talk, particularly from the Far East, about using negative pressure. It's very hard to change our theatres to negative pressure. And the big advantage of negative pressure is not spreading the virus outside theatre, but we don't have much idea of what the impact is on infections in terms of what will happen to the patient. If you turn ventilation off, you've got the worst of all worlds. Your aerosol is going to stick around, not get rid of it. You've got no control over the temperature or humidity. Standby mode is very little better. And there is really no doubt in UK practice that laminar flow should be full on. And this dilutes the aerosol. The only risk is outside theatre. So in your own theatre suite, you have to look where the vents are, where the louvers are, and then have an area outside that you need to avoid so that people are unprotected, are not standing in the outflow. Next slide. So what about prioritization? We're not working in remote and austere environment. We should be able to provide appropriate care for our patients that need it. And we should continue to provide care for open fractures, those with neurovascular compromise, hip and femoral fractures and dislocations, compartment syndrome and spinal trauma. And we have to manage polytrauma, although, as I've said, this is becoming quite rare. For elective orthopaedics, we have to keep a lookout for infection, either in native joints or tissues, and don't forget joints that have been replaced, the infection risk of a joint replacement. Primary and metastatic tumours need to be managed, cord Requiner syndrome and metastatic cord compression. Okay, next slide. We've introduced a lot of strategies to reduce workload, and like many of you, we now provide remote consultations. We've produced a lot of material that patients can access directly for self-management of new and long-standing conditions. We've changed how we manage some fractures from operative to non-operative so that patients can be discharged quickly. The phrase treat to street comes to mind. accepting that there may be a payoff later on of having to perform some reconstructive surgery. We've also invested heavily in material on accident and injury prevention to try and keep people out of A&E. But you have to have robust pathways for time-critical and red flag conditions so everyone in the community knows how to access ongoing management. Next slide. So what about recovery? Before this started, there were in the UK 500,000 patients on our waiting list waiting for elective orthopaedic surgery. And it's likely when this is over, we will have up to 1 million. The patients will be more complex. The surgery will be more demanding and expensive, particularly for arthroplasty when things will have deteriorated. Patients will be deconditioned, so they'll be in poorer physical condition. And I think a really good question that I don't know the answer to is, what is the future for COVID precautions after this? If we're going to have to continue using the full PPE precautions, instead of getting 5 joint replacements done in a day, we'll be lucky to get 2 done per day. So the stress on the system will be huge. So that's it from me. Please get your questions coming in. Delighted to see what they're going to cover. Thank you.
Thank you very much, Phil. So moving on now to our second speaker tonight, Laura Warner. Laura is a consultant head and neck surgeon who has a particular interest in the upper airway. She works at the Freeman Hospital in Newcastle, which is one of the biggest ENT units in the UK. She has taken the lead on PPE and procedural protocols, particularly involving the upper air digestive tract, in consideration of aerosol generating procedures. I'm sure there'll be a great deal of interest in what you've got to say, Laura. Over to you.
Thanks very much, Janet, and hello everyone at home. I wanted to cover a few of the hot topics in ENT, and as Janet alluded to, a lot of things that we do are actually aerosol generating procedures. Can I have my next slide, please, Ryan? So we need to try and balance the risk as much as possible. We want to continue to provide effective care to our patients whilst protecting us and protecting our staff, because we are at risk, and the more virus particles that we get on us, the higher the risk of severe disease. Most ENT consultations will require some kind of aerosol generating procedure, whether this is an elective or in an emergency situation, so we have to try and rationalise this. Our traditional management may not be appropriate anymore, so we have to come up with new strategies to make sure that we're not just left dealing with the sequelae of undertreated ENT conditions. So it may be useful to agree amongst the consultant body and departments a set of standard operating procedures for our common emergencies. What we're aiming for is to streamline the care, and by senior-led decision-making, trying to reduce the amount of hospital admissions as much as possible and reduce the amount of aerosol generating procedures. Running alongside this is the fact that we may be called upon by our ITU colleagues to try and provide support with management there, because we have a set of skills that may be quite useful to them as well. Next slide, please. In terms of emergency care, what we've done in ENT at the Freeman Hospital is actually kind of flip the usual on-call hierarchy on its head, and everything that we do now is consultant-led and consultant-delivered. So we have one consultant triaging referrals and discussing these with GPs, who so far have been really receptive to the advice given over the phone. Any aerosol generating procedure that needs to be performed should be performed by a consultant ideally, or at least discuss with the consultant to make sure that this is actually going to change management. And we are adopting full PPE even in those COVID unsuspected cases, because we know that the peak of infectiousness is actually before the onset of symptoms. For epistaxis, we've changed the way we're managing these patients, trying to avoid hospital admission using dissolvable packing or topical hemostatic agents like FlowSeal, but also thinking about risk factor management, and the GPs have been really helpful with this. For those patients who do need a higher pressure pack, we've worked out a domiciliary packing regime where the patients come to our emergency clinic every day, hopefully just kind of being packed one day and having it removed the next, but they're attending, providing they have adequate support at home, attending clinic and then going home in the interim. The aspiration of quinsy has been identified as a high-risk procedure, and there's been some advice to try and avoid it where possible, whereas we feel in our department this might lead to the risk of parapharyngeal abscess or prolonged hospital admission for those patients who are undertreated. So it's a procedure that we've decided that we will continue to perform, but making sure that it is absolutely indicated and performed by a consultant. Next slide, please. Where possible, we're trying to avoid emergency sinonasal procedures, so only operating where robust conservative management has failed, and avoiding high-speed instruments where possible. Our speech and language therapists are working really hard to try to make sure that patients are provided with plugs and drink thickener and even Foley catheters so that they can manage valve leaking and valve extrusion at home if it's not safe to get them into the hospital at that point. The risk of steroid courses in the community is something that we're asking GPs to have a discussion with patients about, so that risk needs to be balanced, but the patients should be involved, because actually saying to patients, we're not going to get the traditional management of steroids for your Bell's palsy or your sensorineural hearing loss, they need to understand that it's because their current risk is higher from the immunosuppression potentially. Next slide, please. Emergency airway management will be ongoing throughout this crisis. Where possible, we've tried to identify those patients who are at risk of developing an airway complication during the COVID crisis, or if they were to contract COVID, who would not be best placed to deal with it because of the respiratory implications of already having an obstructed upper airway. So we've got as many as possible of our benign airway patients in and treated before this really hit, to try and make them as safe as possible for the future. And we're continuing to treat early laryngeal cancer to try and reduce the number of patients who present at a later date. For those patients who do present in an emergency with an obstructed airway, everybody should be wearing full PPE that's involved in treatment from A&E all the way through, because these patients are highly aerosol generating even just themselves before you've got them into theatre and you're thinking about their surgical management. So the full FFP3 mask, visor and the full gowns are indicated. We are avoiding using high flow nasal oxygen and avoiding debulking procedures which are highly aerosol generating. But unfortunately, tracheostomy is unavoidable and we're still performing these procedures. What I would suggest is that the people who are most familiar with the procedure and most comfortable performing it, particularly with certain safety adjustments that have been suggested by the ENT UK and the BLA guidelines on tracheostomy, should be performing the procedure where possible. Next slide, please. What we don't know is how many weaning tracheostomies are going to be needed in COVID patients. The theory is that we should be waiting for at least 7 days because there is a reduced viral load, but also because the more severe cases will be managed prone, and tracheostomy in these patients, when they're prone positioned, can be quite complicated. In an ideal world, most surgeons would feel most comfortable performing tracheostomy in theatre, and if a negative pressure airflow is available, then that's ideal. Having said that, we need to consider the risk to the ICU nurses of transferring COVID patients, because every time they detach and reattach the ventilators, that's an aerosol generating procedure, so they're putting themselves at risk by insisting that it's done in theatre. And we might also end up in a situation where we don't have the theatre capacity to provide tracheostomy, so we may be asked to do bedside procedures. The approach, whether it's percutaneous or an open approach, there's no evidence to suggest that one is better than the other, so whoever's performing the procedure should select what they feel most comfortable with. In my experience, a percutaneous approach in a bedside setting is actually slightly easier, and simulation training can be useful here. The use of tracheostomy teams is something that's been indicated by ENT UK guidelines, and this can be quite useful because you have a team of people who get used to performing these procedures. They get really slick at donning and doffing the PPE, but also very aware of the safety adjustments, which can be outlined in a standard operating procedure developed in department, but some of the adjustments to the way the procedure is formed are outlined in the guidance, which can be really useful. Next slide, please. So where possible, simulation training can be really helpful for the whole team. So in our in our department, we have set up these PIGS larynxes with either a percutaneous or open procedure that can be practiced on them, but also invited the anaesthetists as well to get familiar with using a bronchoscope if they're being asked to do a percutaneous approach, say if there's not something that they would normally offer as part of their role. And we've invited other specialties as well, like Max Fax and some of the endocrine surgeons who perform surgical tracheostomies, maybe coming to have a go, and just making sure that they're as familiar as possible with both procedures so that they're arming themselves with the skills to deal with this. Next slide, please. And then just a quick comment on head and neck cancer management. Across the country, because of the COVID crisis, we are having to make difficult decisions around NDTs. We're rationalising the use of chemotherapy because of the potential effect on the patient's immune system, and at present avoiding transoral laser microsurgery and robotic surgery because they're both highly aerosol generating, and we need to try and reduce the exposure to staff where possible and where there's an alternative approach that's adequate for the patient. We're using hypofractionated radiotherapy courses, and our ENT consultants are joining our oncology consultants to try and help with the radiotherapy floor clinics to see staff there, to see the patients there. There are some cases where head and neck surgery will still need to go ahead, and these procedures need to be rigorously planned by the operating team, by the anaesthetist and the team in theatre. In an ideal world, there is bits of the procedure that can be done before you need to don the full PPE with an FFP3 mask, but there will be parts of most head and neck surgery where you need to put the full kit on. And if anyone's spent a lot of time in it, you'll kind of know that it's quite uncomfortable. And after a while, you can feel the air escape around the nose. So you know that you're perhaps not being as protected as you want to be. We have to balance the kind of the changing of the kit with the fact that we may well be running out of the standard masks. And the role for respirators and surgical hoods is something that we've discussed within the team, that we're not entirely sure what the evidence is, but it's an option that we're exploring and hoping that our trust will support us in this. But the discussions are ongoing, and I think the risk of this should be considered. A further thing to consider is the psychological implication of operating when you've got ill-fitting PPE in an extended procedure, and that does have a negative impact upon the surgeon. We're making plans to mitigate the fallout at the end of this, and that it's essentially trying to continue to see as many patients as possible. So we telephone triage all 2-week waits and urgent referrals, and seeing just the patients who have a high suspicion of cancer. We're trying to treat early disease where possible. So early larynx, we're treating with cold steel resections as opposed to transoral laser to try and minimize the aerosol generating aspect of the procedure. But we're also thinking ahead for what things will be like when the lockdown lifts and we start to see patients again. And we're planning for how we're going to deal with a potential spike in the late presentations that unfortunately is inevitable as patients don't come and see us as often. So that's everything from me, and thank you for listening. I'll look forward to answering some of your questions later.
Thank you, Laura. So our third panellist tonight is Roger Curry. Roger is another fellow Royal College of Surgeons of Edinburgh Council member, consultant oromaxillofacial surgeon for NHS, Ayrshire and Arran. He is also lead clinician for skin cancer in the West of Scotland Cancer Network. Thank you, Roger.
Good evening. Thank you, Janet, and good evening, delegates. I'm going to try and present some of the evidence and planning that we've undertaken in oral and maxillofacial surgery, and some of it is very collaborative, akin to our orthopaedic and ENT colleagues. Next slide, Ryan. Thanks. So effectively what has happened, as Phil has alluded to in orthopaedics, essentially all elective oral and maxillofacial surgery has stopped. And the 3 principles that are being used at the minute across the United Kingdom are avoid, restrict, and abbreviate. We're trying to avoid unnecessary patient contact. We're trying to restrict unnecessary contact, and we're trying to abbreviate everything so one treatment opportunity is offered. General dental practices are all closed. In various parts in Scotland, we have the public dental service. In England, there's the community colleagues, and these people are providing some degree of triage. As Phil has alluded to, our trauma load has reduced also. We've had no motor vehicle accidents, no sport, significantly reduced interpersonal violence, but we have a big potential problem with the projected increase in domestic violence. That has yet to manifest, but is one of the things we are talking about. And like other specialties, we've gone to a consultant-led and provided service, and as our juniors are effectively dental core trainees, a number of units have looked at amalgamating and supporting ENT colleagues on ward-level activities. Next slide, please. So what are the aerosol-generating procedures in oral and maxillofacial surgery? Effectively, we have split this down into clinical examination and instrumentation will be an aerosol-generating procedure. Outwith of that, examination of the head and neck for a skin lesion is a potential droplet PPE procedure. We have a number of changes to treatment strategies. In simple infections, we are trying to get away with high-dose antibiotics and community management. And if that fails, then exodontia and extraction of the offending tooth is the way forward. There is no place for any other halfway house, such as pulp removal. Our big concern is complex, and as Laura alluded to, the parapharyngeal abscesses. This can come with massive orofacial sepsis, and this will mimic COVID because these patients will be septic and have a temperature, and these will provide us with problems. We're also cognizant of the loss of children's dental general anaesthesia services throughout the country because these children have unmet need, and we know it is the most populous general anaesthetic procedure carried out in the country, and these children will present in extremis and need treatment. Next slide, please, Ryan. So, aerosol-generating procedures are exactly as defined in orthopaedics, use of drills, saws, and handpieces. If we're going to treat fractured trauma, we will need to drill and place plates and screws. An infection will present as akin to this OPT, which shows some infection around a wisdom tooth. So we do have essential aerosol-generating procedures, which we will still need to undertake in full PPE. Next slide, please. What about trauma? There's a little controversy over dental trauma. There's a split as to whether it's even treated at all. Some places are treating it, but if we follow the avoid, restrict, abbreviate, these would need 2 or 3 or maybe 4 potential outpatient exposures, and probably is not a good use of resource. Mandibular fractures, it's been discussed to go back to old-fashioned methods of intermaxillary fixation or leave them untreated. But there's also a school of thought that if we take full PPE, carrying out what we would normally do and providing the best standard of care is the safest for patient and surgeon. I think there's fairly clear agreement that orbital fractures without restriction of eye movement would not be treated, but those that have restricted of eye movement would require operations and intervention. Again, there's probably pretty clear view that zygomatic fractures are probably left for the post-COVID secondary reconstruction. Next slide, please. So what have we done? We've done a lot of what the other colleagues have done. We have promoted remote consultations, including photographs, and it's amazing how the quality of photography has improved in the last 2 weeks. We've put in place robust pathways for time-critical or red flag conditions with consistent consultant-delivered vetting and consultant-delivered treatment. Next slide, please. What about the recovery phase? Well, one of our concerns will be when will the return of theatre capacity match, and as Phil has alluded to, the potential of a second COVID spike. And as Laura has alluded to, we've got significant issues with prognostic and staging changes in head and neck and skin cancer. I think we're fairly clear now on a strategy for managing for skin cancer in stage 1, stage 2 disease, in situ disease, BCCs won't be treated. But we do have to be cognizant that the treatment of stage 3 and stage 4 malignant melanoma would require immunotherapy, and this again puts patients at risk. Final slide, please. Thank you.
Thank you very much, Roger, and thanks to all our speakers. I think we've had a very good overview. Now, as Phil was our first speaker, the first questions that have come in have been addressed to him. So as you may have seen, Phil, a question from Amit. Is suctioning itself aerosol generating, would you say?
Right. No, I don't think that's the case. I think suction can be used quite safely, and that's certainly not on the list. Straightforward surgical suction. It may be different in the head and neck world, but for us, no, it's safe.
And another question, this is from Arpit. What would you regard as the risks of percutaneous pinning, which I gather involves a low-speed drill? Not something
I think trying to judge how fast your drill goes is not really going to help the situation. I think all power tools, basically, they're going to produce aerosol. What is a really interesting question, though, is about the viral load in blood. For my two colleagues who presented, you're operating through respiratory secretions. I think that's very different from operating somewhere below the knee where it's just blood or bone marrow. And the viral load there may be very low. But the trouble is it's maybe. We don't really know. And I think it's a risk that you can't take. So I think that it should be regarded as aerosol, even if it's purely blood, rather than respiratory secretions.
Well, I'm glad you brought that up, because Paul had asked precisely that question, the risk from viremia. There's also a question from Tom about modifications of hip fracture management, perhaps considering more non-operative methods in older people, probably going back to what happened when I was a trainee, as I recall. Any comments about that?
Yeah, it's a very difficult one. Those patients who are clearly in extremis with very limited lifespan, sure, analgesia may be the best option. But for those in any other circumstances, the best analgesia and the most dignified way of managing a patient with a hip fracture is to operate on it, accepting you're going to have fairly high mortality. Other methods of pain relief really don't work very well. So I think we should stick to surgery as being the appropriate way of managing hip fractures unless you're in extremis.
Mm-hmm. There's also a question about looking at things from the outside. I think if I interpreted Andrew's question correctly, that if you're close to the outlets of laminar flow, should you be wearing PPE because all the stuff's kind of wafting towards you? Is that?
Yeah. Yeah, it depends. How you manage this depends very much on the sort of anatomy of your own theatre setup. So you really have to do a walk round and decide whether you're going to set aside a section of theatres that are where you're going to be doing your really high risk AGPs. And you can then generally work out quite easily where it becomes safe through some double doors going into that area where it's absolutely fine. But then you've got those areas which you think may still have some viral load, even though it's very dilute. And there you would definitely the staff should still be wearing at least face masks.
Okay, so I'll give you a rest for a couple of minutes. And we've got a couple of questions here for Roger. One asking a bit about maxillary fractures and nasal fractures. Laura, also you'll be involved in nasal fractures. So could we hear maybe a little bit, first of all, from you, Roger, about maxillary and nasal fractures?
I think our protocols for nasal fractures, unless there is some other reason, these would be left untreated at this time. Maxillary fractures are fortunately of low incidence. They're usually as a result of massive road traffic accidents or interpersonal violence. And I think there's some thinking that because those are both dropped, we may not see significant midfacial trauma. And it then comes down into the treatment pathway. Do we treat it conventionally, or do we look at an old-fashioned method such as intermaxillary fixation? And I think those need to be judged on the patient's comorbidity and age and general health status. So it is something we have thought about, but it's of a lesser frequency facial injury.
Good. There's also a question, Laura, were you going to come in on that as well?
Yes, I was going to say, in a very similar kind of feeling, we're hoping that the number of nasal fractures that were referred does go down. And at present, we are seeing patients with nasal fractures with a suspected septal hematoma or another complication such as prolonged epistaxis, but we're not seeing the routine slight deformity nasal fractures at present. And hopefully, as people are out and about less, there will be less of these coming through the door anyway.
Thank you. There's a more complex question, Laura, that's just come in from Vinod, asking essentially if you would consider interventions for non-functioning larynx at this time. Patients who have had, considering not just a non-functioning larynx, I think the question implies disease present.
So laryngectomy procedures is it's a really tricky subject because it's a procedure where there is quite a long period of time where the trachea and the pharynx are open in theatre, so it's highly aerosol generating. But there are patients who, if they don't have a laryngectomy, they are at risk of aspirating or at risk of airway obstruction in the non-functioning larynx setting. However, I think where possible, a tracheostomy should get these patients stabilised and out of hospital probably quicker than a salvage laryngectomy would, particularly given the fact that we should be avoiding free flap surgery at present where we can. But in the context of a T4 larynx obstructing disease, if we were to place a tracheostomy and treat them with radiotherapy, we know that's going to be ineffective. And therefore, in certain cases like this, we have proceeded with surgery within our department. There's been some debate about whether we aim for negative swabs first and the merit of this. And our infectious diseases colleagues have actually said that negative swabs don't entirely rule it out. It's not a good test when used in that context. So when laryngectomy procedures have gone ahead, we have advocated full PPE, the minimum patient staff attendance in theatre, and done mobilisation of the larynx as a kind of before everybody dons the PPE, so that it is essentially closed until the point where we open everything.
Coming back to you, Phil, another couple of questions picked up. One quite recently come in from Nauful about arthroscopy. I mean, is this a time when you're considering arthroscopies?
Yeah, there are probably very few indications for it at the moment, except maybe the locked knee due to a loose body or a locked meniscal tear, which is causing major problems. I think with this area, it is not going to be an aerosol generating procedure as far as the surgery itself is concerned. So I think you would be safe at the next level down for doing that, providing anaesthetically everything is straightforward. So face mask, fluid resistant face mask, definitely still covering the face, with a visor though. So you still need a reasonable level of protection, but you're not at the highest level if you're definitely not going to be doing an AGP.
Thank you. Coming back to Roger here, sometimes, excuse me if I'm not quite so fair with the jargon and the different specialisms, did you see this anonymous question? What's your opinion regarding the use of suction or the 3-in-1?
Well, suction, I think in the head and neck, it's slightly different to what Phil said from orthopaedics. We would see suction as an aerosol generating procedure, and if we are undertaking an oral cancer biopsy in the outpatient facility, we would not use suction on that reason. A 3-in-1 is a dental thing that restorative and high street dentists use to blow air and water, and would have no place in OMFS or any sort of hospital-based surgery.
And then the question about a simple extraction. If somebody gags as they're having an extraction,
and that's a good point. In technical terms, a simple, straightforward exodontia should not really be an aerosol generating procedure. But that's why we've used the term examination and instrumentation, because if somebody does gag, akin to when you're examining the posterior third of their tongue or looking at their pharynx, that then becomes an aerosol generating procedure. So we would treat that with full FFP3 PPE because of that potential risk. And again, what we would try and do is try and do it in a sessional basis. If we had 2 or 3, clump them all together to try and avoid, restrict and abbreviate.
And Laura, turning to you now, there's a couple of questions about tracheostomy. One is from Kate Conroy saying, if you've got a situation pre-COVID where the intensivists are maybe doing a lot of the percutaneous tracheostomies, how do you regard the balance of roles between intensivists and ENT surgeons during the COVID situation? Would that be changed systematically, or would you regard ENT as still only coming in on a more occasional basis?
So I think the honest answer is we don't know how many tracheostomies are going to be needed. And in a situation where your intensive care is normally quite self-sufficient in terms of doing their own percutaneous tracheostomies, where they still have the staff and the availability to continue and they're not needed in other areas, then they may want to continue in that way. But what we've been doing is actually offering them support to say that as part of your escalation plan, you can call upon us and you can outsource some of these procedures to us because we're here to help.
Then there's another kind of related question like that from Hala, which says if you do identify a tracheostomy team, you outline the practical advantages of that, people getting very expert with assessing the situation and doing the procedure with the different circumstances. But does that subject those individuals, not simply because they're having more opportunities to be exposed, but a higher viral, cumulative viral load? Are they at super risk, so to speak?
Yes, I think there is definitely that potential. And so your team would need to have enough members in it who are rotational. But ultimately, reducing the amount of viral exposure from the procedure, there is probably an advantage for people who can do the procedure in the way to minimize that. So overall, the team is getting less. I think these have to be balanced within departments. And if you have the capacity to have a large tracheostomy team, say with 5 or 6 ENT consultants, as we do, who rotate through, then that may be advantageous, but it is going to differ for different units.
Thank you. Quite a lot of questions have come in about what we're going to do afterwards. I don't know if, I think that's possibly, it's been referenced a little bit so far in the presentations, but maybe if I could ask each of the panelists in turn to give us a couple of ideas as to what they see being the main challenge. You presented some very powerful numbers, Phil, at the beginning about what the backlog's likely to be. Obviously, sometimes conditions are self-limiting or people reprioritize surgery in their scheme of things. So it might not be just the total arithmetic sum, if you like, of what's waiting and what's new. What do you think, Phil? What's the main challenge going to be after it all?
Yeah, I mean, I think you're quite right. The new normal is going to be different from how it was before, and people may reprioritize what they think is a problem that requires a surgical intervention. Some patients do stabilize with osteoarthritis and they continue to cope. But many, particularly with hip osteoarthritis and knee osteoarthritis, really deteriorate, and the operations get more difficult and the outcome gets less good if you wait and wait. I think the problem we're going to have is that, as the other speakers have so eloquently put, that there's going to be a lot of cancer patients there who are going to be in even more trouble than some of the osteoarthritic patients. And it's going to be quite a challenge, I think, deciding on prioritization here if we're still restricted by our access in terms of surgeon numbers and access to theatres and duration of surgery. So I think we are going to face a really serious problem when we get to the end of this.
Thank you. Laura, what do you think? Is it mostly going to be around cancer or?
Well, I think perhaps the cancer cases may need to be treated more urgently than some of the routine cases, but we can't, there's a lot of conditions out there that if we're not treating them for 3 months, they're not going to go away, such as cholesteatoma surgery, sinusitis, and actually their situation might be getting worse. So we need rigorous planning to prioritise the kind of caseload coming through, but also we need to consider the fact that after what could be a very busy period for it, there could be significant staff burnout, and so we do need to balance that and protect our workforce as well as trying to get the patients through. So kind of almost like saying if we're going to open the gates and we're going to treat everything, we're going to be almost busier at the end of this than we have been during it, which I don't think is going to be good for the workforce.
And Roger, if we get you to unmute and...
I would echo a lot of what Laura has just said there about the workforce and protecting the workforce. So in OMFS, as dentistry has closed down, we have lost that referral source. So that will come back on stream at some point. For skin cancer and head and neck cancer, there will be a number of patients whose disease will be significantly upstaged, and their treatment protocols will become significantly more complicated, which may take time and rediscussion at NDT. And also, there'll be the whole burden of unmet need of the skin cancers that we're not seeing, and these people will need treated. So there will be a significant bulge of work. One of the things we have done in our vetting process is put in a new category called urgent cancer suspected deferred. And that allows us to pick those patients when we are vetting that once things come back to normal, they're the first ones we see. And we've gone through and re-vetted everything that was previously an urgent and recategorized those into routine, or carried out a telephone consultation. So we're trying to get ahead of that curve, and I'm not sure we will, because we have dentistry turned off, and when that comes back on, there will be a huge unmet need.
And just coming back to clarify with you, Roger, a couple of questions about oral examination. There has been a question earlier on in the evening from Stephen about pre-rinsing with peroxide, which I gather the American Dental Association might have recommended, and also a question about how severe a protection do you put in for any oral examination?
So Professor MacLeod is erudite in his questions, and peroxide's not really used in the UK, but there is some evidence from our microbiologists that rinsing with Corsidol, chlorhexidine, will reduce the viral load. So that's one of the things that we're doing. And I think you really make the point that it's an aerosol generating procedure. So if you can carry out an examination where you don't promote a cough or a splutter, then it's not an aerosol generating procedure. So it probably does not need FFP3, but that's where the grey area comes in and makes it very difficult with ENT and OMFS. And we're going for a balanced, pragmatic approach that droplet PPE is the standard norm, unless there is an increased expectation of aerosol generation. And that's partially pragmatic and partially to protect PPE.
Yeah. There's a question, Laura, which I don't think is one that can be readily answered uniformly, about the time on a ventilator. This business about a little perhaps discussion more about that would be helpful for our delegates.
So in the discussions I've had with my colleagues in intensive care, the feeling is that within the first 7 days, patients are likely to be managed prone, and there'll be a high viral load. So tracheostomy should be avoided here. After 7 days, what they're seeing is quite a few patients are either turning the corner and they're ready for extubation, or if they're still needing to be prone after 7 days, that their prognosis is pretty poor and tracheostomy isn't indicated there. So the feeling from the intensive care team is that 7 days is a good deciding factor, because it's a safe time to provide the service, but also gives you a good idea of how the patient is going to be progressing one way or the other.
Thank you. There have been quite a few questions, Phil, well, for all of the panellists really, around the use of FFP3 masks in patients who are not COVID positive, and about testing before surgery. And of course, that raises a whole lot of questions about the sensitivity, particularly if a patient doesn't have symptoms. I think our hospital says it's probably got a 50% accuracy if the patient's asymptomatic. So you could say that every patient is potentially COVID positive unless we know they've recovered from a previous infection with it. And I think it is problematic for people to weigh this up practically. And I think if there weren't some shortages, it might not be such a vexed question. What do you think about this?
Yeah, certainly in the department I work, we're running it as all patients are COVID positive. And you can't really prove otherwise. That's the problem. As you say, there's a false negative test. And we just cannot run that risk, I think, with the AGPs anyway. So I think we are where we are with that, accepting that we are short of PPE, and there are all sorts of issues around this, and fit testing, and shortages of the testing fluid, for example, and using a different mask from the one you were initially fit tested with. There's all sorts of issues around it. But safety of the surgical and nursing workforce and the anaesthetists has to be at the top.
Thank you. Laura, questions coming in about our approach to diagnostic nasendoscopy and laryngoscopy, and also questions about, should we be doing mastoidectomy? Should we be operating on aticoantral disease at this time?
So in terms of the diagnostic endoscopy, there will be situations where it changes your management, but there will also be situations where, from taking a history from the patient, you're highly suspicious of there being a malignancy, and you would progress to imaging even if, say, you didn't see it on your examination, in which case our radiology colleagues have been really supportive to say that if an examination is not going to change the management, they're happy to accept referrals for imaging whilst they have the capacity in patients that we haven't examined. So that's one way forwards. But I think ultimately, if it's going to change your management, then it should be done just with the adequate protection, and an FFP3 mask for a short procedure does feel like adequate protection with a visor and a full gown. In terms of continuing to provide mastoidectomy surgery and sinus surgery, I think that is a really tricky decision to make and needs to be balanced against the risks to the patient of coming into the hospital for a procedure versus isolating themselves at home, but also the risk of using high-speed drills, microdebriders in the surgery as indicated. And I think if this is a patient who can wait for 3 months quite safely without you worrying about them developing the sequelae of their disease, then they should wait.
Thank you. And moving on to a question for Roger, should we perform, I think you've partially addressed this, a question from Asif Nazir, should we perform only airway compromising and bleeding related procedures and refuse all others, or oral cancer and facial trauma, should that be going on?
So I think absolutely, airway compromising and bleeding procedures, the arrest of hemorrhage and the potential stopping of the spread of infection, we're going to have to address those. Facial trauma comes into that grey area of the informed discussion with the patient and other colleagues. And one of the principles is, whilst there are other treatment methods like self-drilling screws and intermaxillary fixation, if those aren't your normal treatment methodologies, are you increasing the risk to yourself and the patient, or would you be better using your normal treatment methodologies and using FFP3 protection? So, and in terms of the oral cancer patients, there is still biopsies are being carried out for diagnostic reasons. And as Laura has alluded to, our imaging colleagues are very happy to scan patients for staging. But whether we have the ability to carry out significant head and neck microvascular free tissue transfer is questionable because of the intensive care resource that needs for a non-COVID patient. And there's an acceptance that those will then potentially be patients who become inoperable or present with obstruction, airway obstruction to the emergency department. So it's a very difficult balance. And I think all of the MDTs, the head and neck ones and the skin cancer ones, are taking these decisions with all of those provisos in place.
Thank you. A question, I think you did address it about coming in with nasal packs and being sent home with packing in. I think we've changed practice to deal with this. There's a question here, a practical question from Jared about using loops, which perhaps any one of the three of you, just how you accommodate that with full PPE protection.
It's not from my personal experience because I don't use loops or glasses, but from talking to colleagues, particularly plastic surgery colleagues, they're having real difficulty with the PPE and the FFP3 masks and getting a fit, and also having the visors. There's been some research into kind of full face shields that you may be able to wear over the top of loops that might be more effective, or some of the kind of full face respirators do accommodate, you can have some eyewear underneath. I think there's a number of things out there. We did researched this as a department to see whether the full face respirators or even half face respirators may be useful. Unfortunately, the ones that we looked at came with huge disclaimers from the company to say these should not be used for against viruses or other airborne particles. So the level of protection they give is unclear, but providing surgery in these contexts is really, really challenging and has quite an impact upon the psychology of the surgeon as well.
As a loops wearer, Janet, I have been lucky enough in that my loops fit reasonably well over my FFP3 mask that I've fitted for. And what it's just needed is with the visor to have an extra layer of foam just to take it out from your face, that other centimetre.
Thank you. Any comment, Phil, from you on that? Or it's perhaps
no, it's no. For me, it's just trying to get the glasses to fit, and I've got two pairs of glasses, one that works really well and one that doesn't. So I've just had to change the ones I use.
We've also had a question about headlights, whether we're wrapping them in plastic bags or equivalent to prevent splash, or do we just Clinell wipe them down afterwards?
Good clean afterwards.
Yeah. There's an interesting point about lights, actually, that comes into that, Janet, is the laminar flow is really disturbed by the operating lights inside the laminar flow. So it's good practice, in fact, to either keep them as far away, as far apart as you can from the operating field, or even don't use them at all and put them right outside of the field. So just thinking about lights, it just came to my mind.
Thank you. And while you're speaking, could I start you perhaps the ball rolling? There have been a couple of questions from trainees about the implications for training. As Laura explained, there's been a great drift towards consultant-delivered service, partly to minimise the number of episodes of care being delivered to any patient and the number of episodes of risk, and also perhaps to protect junior doctors. It's not an easy question. I guess it's only now we're beginning to draw breath, beginning to look at the slightly longer haul where this becomes relevant. How have you viewed that from the BOA perspective?
Right, well, we very much support the JCST approach to this, and that trainees should not be seriously disadvantaged by having to go through the process we're in at the moment. But there are major implications for recruitment, selection, training, ARCPs. It's very complex, and I think fortunately next week's programme is actually going to address that. So it is a serious worry. I know all our trainees are very anxious what the future holds, but I hope next week's webinar should have some more detail on that.
So that's a reminder to trainees dialing in tonight to be there next week to get the focus on them. I guess I'm just going to ask perhaps each panellist to give one final comment that they might have spotted from questions coming in that I've not picked up during this evening, because we've just got the last 2 or 3 minutes left this evening. Laura, I don't know if you've spotted any questions that we've had various questions about doing DCRs and other lower level ENT procedures. I think you've kind of addressed that.
I think I've seen a few questions about local anaesthetic tracheostomy, and I think ultimately this is going to be needed in emergency situations, and these situations there isn't an alternative for the patient in most cases, so it's a procedure that we should continue to perform, but making sure that we are fully protected with our PPE. There's one question from Andrew Robson that I'd like to address. He's said that there will be opportunities to change practice for the better in the long term. And I think I would completely agree that already we're seeing engagement with the GPs who really appreciate discussing cases with a consultant, being able to manage risk factors, being able to treat patients at home where possible. And I think this is one of perhaps the health legacies that might come out of this, is the fact that treating these patients in a more streamlined and more kind of a thoughtful manner might actually be quite positive in the long run.
Thank you. Roger, comment from you?
Thanks, Janet. I picked up on 3 things briefly. Lacerations and using full PPE for that would not be something we would be looking to treat lacerations as simply as possible, potentially with glue, and droplet PPE would be adequate for that. I think the issue has been raised on a number of contributors about extractions. Extractions have the potential to become AGPs. They can become surgicals. They can create oral-anal communications. So I think the evidence would be that we treat those as AGPs. And there's a very reasonable question from Alistair Smythe on relation to using external approaches rather than internal approaches for fracture fixation of mandibles. And again, this has the potential of reducing the aerosol generating procedure, but we would still be looking at the oral cavity. So it comes to balance with the experience of the surgeon, what the surgeon's used to, and the team approach to that. So there's not a one-size-fits-all answer.
Yeah. Phil, have you got anything? I've spotted another couple, but if you have anything you'd like to...
Right, yeah, a couple of questions alluded to it, but it's the impact on paediatric orthopaedic practice, which is something we've not really addressed. So trauma for children should continue as it is. And it's interesting that we are seeing people trying to avoid coming into hospital either because they fear they're going to develop infection or they don't want to overload the system. But then children are coming along with displaced fractures, which are just not being looked after appropriately by not presenting. And this brings all sorts of concerns about non-accidental injury and all the rest that comes with it. And also children clearly have not particularly time-critical problems, but problems which may not do well if they're left. So clubfoot and congenital dislocation of the hip, for example, these still have to be managed appropriately. So we don't want to forget the paediatric side of practice.
Thank you. I'm sure there'll be a more discussion of paediatric topics in later webinars. Somebody has asked how we regard anosmia as a symptom for COVID-19. I think in the ENT world, it's fair to say, Laura, that we are very aware of early and severe, but potentially short-lived. We don't quite know yet how long-lived anosmia has been much more frequent. It can occur after any virus, but we're seeing a lot more of it. And it does seem to be a marker for COVID-19, although it is not yet, as far as I understand, on official WHO guidance, but these things change, as we know, on a daily basis. I think we've been very fortunate tonight. We've had a wonderful panel of speakers, so very well informed, and a great audience in yourselves. You've been fabulous with all the questions, and look forward to seeing you at the next RCSEd webinar on COVID-19 very soon. Good night from all of us.
Good night.